Welcome to The Explainer. Today, we're diving deep into a pathogen that you've probably seen but maybe didn't recognize. We're talking about Aerococcus urinae, an organism that really loves to hide in plain sight. It's often called a wolf in sheep's clothing, and for good reason. For years, it's been written off as just a contaminant. But as we're about to find out, this thing is a master of disguise, and it can cause some pretty serious problems. Just so you know where all this is coming from, everything we're about to cover has been pulled together from a comprehensive Gemini deep search of the latest literature. The awesome visuals you'll see are from Microcanvas. We've really geared this for you, the practicing medical microbiologist. And if you want to go even deeper, all the sources are right there for you in the accompanying notebook. All right, so here's the game plan. We're going to kick things off with why this bug is such a problem. Then, we'll hit the lab bench and tackle the diagnostic headaches it causes. After that, we'll cover how to nail the ID, what diseases it actually causes, and wrap up with a solid treatment playbook and some key takeaways. First up, the hidden pathogen. Let's talk about why we even need to be discussing Aerococcus urinae. It's got a fascinating history of being totally overlooked, but now it's a recognized and clinically significant uropathogen. Okay, so where does this guy fit in? Taxonomically, it's a lactic acid bacterium. The thing is, its family tree is full of usual suspects we see in the lab every day, and that's exactly where the trouble starts. For years, it was misidentified as a streptococcus, a staphylococcus, or an enterococcus. And that whole case of mistaken identity, it's really the core of the story here. All right, let's head over to the bench. This is where Aerococcus urinae really shines as a master of mimicry, setting up these classic cognitive traps that can catch even the most seasoned techs off guard. So you get your slide on the microscope. What are you seeing? Is it a staph, a strep, or something else entirely? The gram-stain morphology is just notoriously ambiguous. You know it's a gram-positive coccus, but how it's arranged? Well, that's the first piece of the puzzle. And this is where it gets really tricky. You see gram-positive cocci in tetrads and clusters. Your brain immediately screams staphylococcus, right? But then you run the catalase, and it's negative. Okay, so scratch staph. You pivot. Maybe it's a streptococcus. That would fit with the alpha-hemolysis you're seeing on the plate. But here's the other catch. It's a slow grower. At 24 hours, it's just these tiny pinpoint colonies. It's so easy to overlook or just call it insignificant flora and move on. Okay, so with all this confusion, how in the world do we get a definitive ID? Let's talk about the tools we have to crack the code and finally unmask this thing. So in the world of biochem, the one test you absolutely need to remember is PYR. Aerococcus urinae is consistently PYR negative, and that's huge because its main lookalikes like Enterococcus and Aerococcus viridans are almost always PYR positive. That simple little test can be your first solid clue that you're on the right track. But of course, these days, we have a real game changer. I'm talking about MALDI-TOF. A score of 2.0 or higher gives you a confident, species-level ID. It just cuts right through all that gram stain and biochem guesswork like a hot knife through butter. And the impact of MALDI-TOF has been massive. It's completely changed how we see this organism. It turns out, Aerococcus urinae isn't some new, rare bug that just popped up. Nope, it was here all along, just hiding in plain sight, misidentified as something else. Okay, so now that we know how to properly identify it, let's talk about the clinical side. What kind of trouble does this bug actually cause, and who are its primary victims? No big surprise, given the name urinae, its number one gig is causing urinary tract infections. That accounts for about 3/4 of cases. But, and this is a big but, look at the rest of that chart. It can cause incredibly serious invasive diseases like infective endocarditis and even infections of the spine. And when that happens, the stakes get a whole lot higher. So who should you be thinking about? The classic patient is an elderly man, usually over 65, with some kind of underlying urologic issue, like BPH or an indwelling catheter. And here's a really critical clinical pearl. If you ever see Aerococcus urinae in a blood culture, you have to immediately think about endocarditis or spondylodiscitis. The infection almost always seeds from the urinary tract. Now, what about in kids? Finding Aerococcus urinae in a pediatric patient is a massive red flag. Often there's a report of really strong, smelly urine. This is not something you just treat as a simple UTI and send them home. An isolate like this absolutely demands a full workup to look for underlying structural problems in their urinary tract. Okay, let's get to the really practical stuff. The treatment playbook. How do we actually treat these infections effectively? All right, if you remember nothing else from this section, remember this. Aerococcus urinae is intrinsically resistant to trimethoprim sulfamethoxazole. Do not use it. I'm talking about SXT, cotrimoxazole, whatever you call it. It's a go-to drug for UTIs, but for this bug, it's completely useless. It's a guaranteed treatment failure. So what should we use? Let's look at a quick comparison between, say, the Dutch guidelines and broader international ones. You'll see a common theme, a heavy reliance on beta-lactams like penicillin and amoxicillin. For simple UTIs, nitrofurantoin is a great choice. You'll also see international guidelines bringing in options like fosfomycin, and for more serious invasive disease, ceftriaxone is often preferred because, it has much easier dosing. Now, a quick note on susceptibility testing. This isn't your standard setup. You need specific media, Mueller-Hitton with blood and NED, and CO2 incubation for it to grow properly. The good news? It's almost universally susceptible to penicillin. The bad news? Fluoroquinolones are a different story. Resistance can be as high as 10 to 20%, so you can't just assume it's susceptible. You absolutely have to test it. All right, let's wrap this up and debrief. What are the absolute key takeaways you need for your day-to-day practice? When it comes to infection prevention, the good news is it's pretty straightforward. You don't need contact isolation or anything fancy. The single most effective strategy? Meticulous, by-the-book catheter care. The whole game is preventing that initial UTI. So here's your final checklist. First, suspect Aerococcus urinae, especially in elderly men with UTIs. Second, scrutinize that gram stain. Look for those tetrads. Third, avoid sulfonides like XST. It just won't work. Fourth, confirm fluoroquinoline susceptibility before you even think about using it. And finally, prioritize the reliable options, penicillins for serious infections and nitrofurantoid for simple cystitis. And that's our deep dive into Aerococcus urinae. Hopefully this helps you start unmasking this hidden pathogen back in your own lab. So I'll leave you with this question to think about. How many cases of Aerococcus urinae have been missed in your institution? It's kind of a sobering thought, isn't it? Hey, thanks for watching. Please hit that subscribe button, and we'd love to hear your thoughts or experiences with this bug down in the comments.